just asking a forward-looking question here, but we're certainly seeing, again, that rapid evolution of adjuvant therapies and now perhaps use of novel endocrine therapies in the adjuvant setting and looking at mutational or genomic alterations that occur in response to our therapies, right? Specifically thinking about the ESR1 mutation. Maybe leave us with a forward-looking statement in terms of how you anticipate the adjuvant setting to look, let's say, a year from now even. You had very insightfully mentioned MRD testing and identification of residual disease potentially as a stratification factor. But perhaps we could take that a step further and look for the evolution of resistance mutations and alter our adjuvant therapy accordingly. But maybe with the perspective of those patients with germline BRCA mutations, which my understanding is what's really driving the natural history of the disease, do you see a change in how we might use adjuvant PARP inhibition and how we might layer in new types of risk stratification and new therapies coming down the pipeline?
Right. That gives me a wide field to run in. I think so. I think the immediate, most practical decision that will have to be made is if the topotecan ADCs find a role in the residual triple-negative disease. BRCA deficient cells are very, very sensitive to topoisomerase inhibition, and you cannot combine a topoisomerase inhibitor and a PARP inhibitor because there's sort of almost synergistic toxicity. So I think that decision will need to be made. Is if you have a triple negative patient with residual disease, should you give that person however many cycles of an ADC versus PARP inhibition, and that will become a tough call. And whether or not you stratify that call based upon MRD, whether or not, how we make that decision, I think is going to be a conversation, because I don't think that there's going to be a trial that's going to answer it. In the hormone receptor positive space, I mean, if the main thing that happens is we start using oral SERDs as opposed to AIs, I don't think that's going to have an effect, because there's not going to be any significant overlapping toxicity from that. And so we'll just be swapping out one non-interacting endocrine therapy for another. I don't actually see adjuvant PI3 kinase inhibition coming down the pike anytime soon, unless we develop more less toxic drugs. And we've sort of talked about the CDK4/6 inhibitor landscape. So I don't think we'll see as much impact in the hormone receptor positive space, but we are going to have some decisions to make in the triple negative space.
Yes, certainly will be very interesting times as more data comes through. But I think this has been really insightful to hear your comments with regard to the treatment paradigm in the germline BRCA1/2 altered setting. And I think we certainly covered data, particularly from the Olympia update, which fortifies really the NCCN Category 1 preferred recommendation for using PARP inhibition in our patients that are higher risk and that have germline BRCA1 or 2 alterations, both in the hormone receptor positive and negative settings. We're going to see a lot of evolution, as you alluded to, in the adjuvant space, and I think for now we're certainly helping our patients by targeting this pathway in those patients that have a BRCA1 or 2 mutation.